Welcome, everyone, and thank you for joining us for tonight's webinar, Working with People with Intellectual Disability and Behaviors of Concern, a Practical Approach to Assessment and Management with Dr. Rebecca Kontz. Now, also, huge apology for the technical difficulties tonight, but I'm really glad that I can see people are joining. So thank you for your patience, and I'm really sorry about the mess around. Now, my name is Sydney, and I'm from the PHN Education team. I'm joined tonight by Olivia Gregg from CAMS and Dr. Rebecca Kontz. Now, I'll let Rebecca introduce herself shortly. Before we begin, I'd like to acknowledge the traditional custodians of the land that I live and work on. For myself on the Central Coast, that is Darkinjung country, and I'd also like to pay respect to all elders past, present, and emerging. Now, a few things to let you know about this session. It is being recorded and it will be available for you to view in our education library in a few days' time. As attendees, your camera and microphone are automatically disabled, but we encourage you to put any questions you have in the chat box throughout, and Rebecca will do her best to answer them when she can. At the end, I will post a QR code and a Slido evaluation link for your feedback. Now, your feedback is extremely important as it provides us the opportunity to give you future education. Now, I will hand over. Let's see if Olivia is there. Olivia.
Hi, Sydney.
Hi.
Hi. Okay, thank you, Sydney. Look, a massive big thank you, everyone. I'll backtrack. My name is Olivia. I'm the nurse consultant for child and adolescent mental health on the Central Coast. It's with great pleasure and extreme thanks to Dr. Rebecca Kontz for accepting to present tonight on a topic that is very relevant nowadays. I get a lot of inquiries from GPs about this particular topic and management and assessments of young persons with intellectual disability and mental health. Thank you again to the PHN for enabling that to happen. And thank you, Dr. Kontz. I'll hand over to you.
Thank you, Sydney and Olivia, and for everyone dialing in this evening, it's particularly being the end of a long day for many, I'm sure. So I am a psychiatrist by background. I've been working with adults with intellectual and developmental disabilities for close to 10 years now. I have a clinical appointment with Southeastern Sydney Local Health District, and I've recently taken on the role of Chair of Intellectual Disability Mental Health. So I sit within the National Centre of Excellence in Intellectual Disability Health based at UNSW, sitting within the 3DN team with Professor Julian Troller, having led that team for many years before me. So it's a pleasure to join you. And I do welcome any questions along the way. I too would like to pay respects to traditional custodians of the land on which we're all joining from today, including the significance of cognitive disability and mental health concerns for this particular group. I also would like to acknowledge funders for my role, particularly the Ministry of Health, Mental Health branch, who support a number of members of the team here. So you're all aware of the learning objectives. I think they were sent around as part of the flyer, and I won't repeat them here. And I do think I understand there's a bit of a diverse mix of people online this evening. So I hope that I have pitched the presentation right. But again, welcome any questions to clarify things along the way. In order to meet these learning objectives, I thought I would spend the session kind of in three parts. The first is actually providing a bit of context, the why should we care and how is this relevant to us? What does the evidence teach us? Before diving into some of the more practical components around assessing behaviours of concern with people with intellectual disability, and then finally turning to some of the management principles, particularly aspects around prescribing, which was flagged with me that is understandably a challenge for many working in the primary healthcare setting. So let's start with a little bit of context. Before I dive in to make sweeping generalizations, I think it's really important to acknowledge that we are referring to and working with a really diverse population that is diverse level of abilities and strengths dependent on the level of intellectual disability and its cause, possible genetic factors that might be contributing to that, as well as a range of medical and psychiatric comorbidities that might compound presentations, alongside of their differences in supports, their own personal experiences. Trauma, unfortunately, is very common in this group, as well as the broad range of social determinants of health, housing, different access to education, and so on. So I can't, did I just see a hand there? I'm not sure if I did for a moment. I think it might have disappeared. Okay, thank you. But despite the diversity, there is much in common around the poor health and mental health outcomes that really are facing people with intellectual disability across New South Wales and across Australia. And that includes premature mortality. So that was work done by Professor Troller and the team at 3DN well before I joined them, that demonstrated the median difference is 27 years younger than the general population. And one of the tragedies is that there are twice the rates of preventable deaths compared to the general population, and therefore all the things that you'd expect, cardiovascular disease and so on. There are differences in healthcare utilisation, twice the rates of ED presentations, twice the length of stay for inpatient admissions, which relevant to those perhaps here working in CAMS settings. But for those in primary care, it's interesting that local data shows us that there are differences in the way that we're working with this population. And much of that comes from the BEACH program that many of you might be aware of, but that overall there's less time spent on preventative health needs, more time spent on administrative as opposed to medical or health needs, and significantly higher rates of psychotropic prescribing. And one of the standout was 10 times the rates of antipsychotic prescribing. So significant health and mental health inequities continue to face this cohort. So with respect to mental health specifically, this data was actually just published in Australian New Zealand Journal of Psychiatry, I think just last week. It's a period prevalence of 18 years of linked data of hospital and MBS records across New South Wales that has demonstrated that 3/4 of Australians with intellectual disability will experience mental illness. So that's twice the rate of the general population. And this is from the age 5 years and up. And the thing to note is that they are vulnerable to a broad range of conditions. So that includes higher rates of the spectrum of anxiety disorders, depressions, psychotic disorders, substance use, self-injury, as well as personality disorders. So there's significant mental health comorbidity, and as well as young onset dementia. I haven't featured this here, but it should be included, significantly higher rates. The other thing that's interesting that came out of this data was the significantly higher rates of neurodevelopmental conditions, and I think this will be of no surprise to people working with child and adolescent or paediatric populations, that autism and ADHD are both significantly overrepresented in people with intellectual disability, and arguably our mental health services in the adult sector are fairly ill-equipped to be meeting their needs. And then, of course, is that someone there?
I think it was just someone unmuted, but it's
unmuted.
Okay.
That's okay. Oh, great. And then, of course, this is the mental health comorbidities are compounded by very complex health needs. So This was not data linkage work, but systematic review that demonstrated that compared to the general population, people with intellectual disability are much more likely to have a whole host of chronic medical comorbidities that are overrepresented. So particularly epilepsy being number one, which I'm sure is of no surprise, but of course a range of sensory neural deficits, cardiac conditions, mobility issues, premature aging, and so on. So we can start to paint this picture of how the mental health comorbidities and physical health comorbidities are then interacting with themselves in their presentations, and then of course the disability, which perhaps influences one's ability to communicate their experiences, things like pain, headache, or any thoughts and emotions that might usually be asked about in a mental health assessment. So, for example, someone might present with a physical health complaint like weight loss, but that actually it is a mental health condition like depression that might be driving that physical health presentation. And similarly, someone might be presenting with recurrent self-injury, recurrent slapping of their face or the side of their head that actually is because they have a middle ear infection. So there is this complexity of their presentation that is then compounded by other variants in terms of the social determinants of health as well. So what opportunities there have been for family support, early intervention, education, touch points with justice system in which people are overrepresented as well. So I guess I want to paint that picture of complexity before really kind of narrowing into the issue of when someone is presenting to you with behaviours of concern and how to go about assessing and managing this. So just so we're all on the same page, what am I talking about when we're referring to behaviours of concern? So it's a really old definition by Emerson that really holds true to this day, that we're talking about normal behaviours culturally that are of such an intensity, frequency or duration that there is risk associated. So there's a risk of harm to others or themselves, or that the behaviour is likely to seriously impact on community access or their quality of life. So there are lots of terms that you'll probably come across either in literature or in clinical assessments. In Australia at the moment, we are using behaviours of concern. You may see other phrases, so behaviour that challenges. They are part of the UK NICE guidelines in working with people with intellectual disability. You'll see changed behaviours. That's often kind of used more broadly in people with cognitive disability who might be developing cognitive decline or dementia. Challenging behaviour was a very common phrase, or behaviour problems that I guess we have shifted away from because of the negative connotations that really are associated with that. But unfortunately, in this day and age, still many of my colleagues will refer to presentations as just being behavioural. And there is significant stigma that really is associated with this term. It's not only dismissive, but really implicates this issue of diagnostic overshadowing, where behaviour change is unfortunately misattributed to the disability itself. So one of the key asks this evening is that we are not using this terminology anymore going forward, and that we are, I guess, using terms that avoid this implication of diagnostic overshadowing and speak more to the challenges with behaviour as opposed to the individual. So what are the kinds of things that might come your way it really is such a broad spectrum, and this is not at all exhaustive. But some of the things that might come to you for further assessment are things like recurrent self-injury, aggression, and that could be threatened or verbal aggression, actual physical aggression or property damage. Inappropriate sexualized behaviours, that can be quite a difficult one to kind of assess and manage. Things like inappropriate derobing in public, inappropriate intimate touching, and so on. But it is not uncommon and something that you might be asked to assess and manage. Repetitive or stereotyped behaviour, that usually comes about when it's really disruptive to other people in perhaps a classroom setting or a day program. Social withdrawal, that they may be eating or feeding issues. So this again is not uncommon. So it might include things like picker, not eating, consuming non-edible objects, restrictive eating that may or may not be related to sensory processing challenges that we do see in autistic people, and food-seeking behaviour that is, again, sometimes a real challenge to manage, as well as wandering that can lead to dangerous situations, particularly when people don't have awareness of things like road safety, sleep disturbance, and picking that apart, whether that is at the onset issues with falling asleep, staying asleep, or so on, and hyperactivity that may be associated with impulsivity that can be challenging as well. So this is not an exhaustive list, but just to give some examples that might come your way for assessment, or they already have. And so therefore, the question for us now, understanding all of that complexity in the background, is being tasked with how do we approach the assessment and management of these behaviours of concern. So let's turn to aspects of the assessment, and I will just check. There don't seem to be any questions yet, but please do feel free to send them through. So a very important starting point is really appreciating the breadth of the potential differential diagnoses, the potential contributors to new or changed behaviours of concern. So, I mean, I guess in this setting, things like physical health and mental health are what we might focus a little more on, but really more broadly thinking about what are the perhaps interpersonal difficulties that might be happening for someone, trauma, grief, loss that may have been experienced but not communicated. We do need to have a high index of clinical suspicion for that. What are the communication difficulties that might actually be contributing to these challenges? And environmental factors, a huge component that we need to take under consideration as well. So I guess what's interesting is that colleagues will often come and say, oh, I don't really know how to go about the assessment. But the truth is, if you're a clinician working on the ground with the general population with mental health comorbidities, you actually do have the skills to be conducting these assessments. And it's not that dissimilar to any other presenting complaints in many ways. So particularly when we're thinking about how to approach the description of the behaviour, it's not dissimilar to, I don't know, chest pain as an arbitrary example in terms of thinking about what is the onset what's the nature of it? What's the severity of it? Chest pain might not be a great analogy because that's often associated with very acute situations. But with the behaviour, we are thinking about what's its course, time course. Is it actually episodic? Is it relapsing, remitting? Is it actually progressively deteriorating over time? I'm interested in what is the impact on one's function and one's quality of life, exacerbating and mitigating factors, anything making it actually better or helping in situations or making it potentially worse. But the trick to all of this in working with people with intellectual disability is actually understanding what is that person like? Who are they when they are well? And therefore, and I'm going to come to talk about this in a little bit more detail, but what we're trying to tease apart is it actually a new behaviour of concern, or actually is it part of their usual behaviour phenotype, but worse or different in some way? We obviously need to be thinking about any of the associated symptoms, whether they be related to psychiatric symptoms or other health conditions. And again, is this a first episode or have there been episodes in the past? And what have they looked like? What was helpful in that particular situation? So, and essentially the usual assessment of medical and mental health comorbidities, including medications. So this is kind of the bread and butter stuff that I think actually many people are doing in their clinical practice anyway. So I think it's you should be giving yourselves credit and feeling confident in your ability to address behaviours of concern when they present. But there are some differences. So I've used psychiatric. It probably is more thinking more broadly about mental health assessment plus some specific additional clinical considerations that I think can help all of us to make a bit of sense of what's going on. So we've talked about the bottom two, about the clear time, like understanding the details around the behaviour, including that timeline of things and any concurrent medical or psychiatric symptoms. I guess two things, though, that we do take into consideration are the need for preparation and reasonable adjustments to really accommodate a person's individual needs and preferences to ensure that they remain as actively engaged in their own healthcare as possible. And then understanding what that baseline is in terms of behaviour, cognitive ability and function. So I'll come back to talk a bit more about that. And then there are, I think, specific considerations that can help us to make sense of a presentation around understanding if there is a known cause of the intellectual disability, what the level of intellectual disability is and how that might impact on someone's presentation, whether there are neurodevelopmental comorbidities. I guess in a general mental health assessment, perhaps it's more common in CAMHS, but in the adult sector, we're often not thinking closely enough about how autism and ADHD might be impacting on someone's presentation. The role of psychotropics in someone's presentation is particularly important working with people with intellectual disability because of their high rates of prescribing in this group. And then thinking about investigations, which is quite tricky. How far do we go? And if so, how are we organising those investigations, which I appreciate can be really challenging in outpatient or primary health settings. So we'll spend a little bit of time thinking about each of those and how understanding those aspects might influence our assessment. So just a word on preparation and reasonable adjustments. I think this is something that we do give more time to thinking about working with people with intellectual disability, because accessing a clinic or engaging in a telehealth consult is not necessarily as straightforward as it may be for someone in the general population. So in preparing patients, I guess every different practice setting is going to have different opportunities for this, but some helpful things might be having visual information to help, I guess, people prepare for attending clinics. And I have seen that successfully used in other settings, so that people can be familiarised and prepare themselves for coming in. Consent is another thing that we do think a lot more about, because while consent and capacity to consent is task specific, and for many things, people, particularly in the upper moderate or milder levels of the spectrum of intellectual disability, they may have capacity to make their own decisions about their healthcare and mental health care. Many times that is not the case. So we are thinking, who's the nominated person responsible? Or are decisions having to be made that require a formal guardian, like around restrictive practices and chemical restraint, which I'll come to talk to a bit later on. So preparing ourselves, so much of the work we do is actually the groundwork and the information gathering that does take place often outside of that specific consultation, which I fully appreciate is really difficult in a primary health care setting. But that's where I am quite directive of what I'm asking of support staff to bring in, because often I found myself in situations, I don't know what your experiences are, but some poor support worker who's recently started working with someone has showed up to an appointment because they've been told they need to, but the key bits of information are not there around what is the problem, what is the medication list, and so on. So actually kind of preparing people in terms of what they should be bringing to appointments can, although it takes a little bit of time, it makes for a much more efficient and effective consultation when we're with the patient. And then thinking about the assessment in more detail, is someone actually going to be able to tolerate coming into a clinic setting? Actually, is telehealth perhaps a better option for someone, which is, of course, limiting in many ways, not being able to conduct physical assessments and things, but is an alternative. Many people that I've worked over the years have really struggled to come into a clinic setting, and a telehealth opportunity is better than nothing. So that's a bit around the general kind of considerations around preparation prior to the appointment. Then I've spoken about understanding someone's baseline when they are in the appointment, and I have a fairly simplistic way of thinking about things. This structure is directly from DSM-5, thinking about the domains of adaptive function. And what I'm interested in when I'm with someone is, who are they and what are their abilities when they're actually well versus what are they like now? And I think breaking it down, for me anyway, helps me just to kind of categorize or have a framework for thinking about the skills that I tend to ask about in appointments. And it's really easy to do a quick screen for what their functional capacity is in terms of their self-care, mobility, and their instrumental activities of daily living as well. If I have a little bit more time, I do start to think about, well, what are their expressive and receptive language skills? Can they follow complex sequence questions, or is their understanding much more limited to single instructions? What's their preferred way of, what's their expressive language? How are they communicating either verbally or otherwise, and so on. And then in the social domain, I think that is, again, just a helpful screener to understand what are their day-to-day interactions and abilities socially when they're well versus now. How has that changed? And I think that can give us some really important insights into or hints as to what might be contributing to their behaviours of concern. So that's just a quick kind of reference guide that I have found helpful over the years. So now getting to some of the specifics around or key considerations that I think might not be commonly thought about, but helpful when working with people with intellectual disability and challenging behaviour. So what's the cause of the intellectual disability? Often it's that we actually don't know. And it's perfectly okay. At least we've asked the question. But if there is a known cause, what it can help us to do is anticipate commonly associated medical comorbidities. It might also help us to understand this concept of what we call a behavioural phenotype. So a behavioural phenotype, bear with me, I'll give you some examples, but it refers to a characteristic pattern of behaviour. So that might be motor, cognitive, linguistic or social abnormalities that is more consistently associated with a biological disorder. So in other words, the other description is that a higher probability that people with a particular genetic syndrome will exhibit some behaviour more commonly than those without that syndrome. So let me give a few examples perhaps to help make sense of that. So Down syndrome is a really good example. I think that perhaps many of you have come across in clinical practice that with trisomy 21, they're much more susceptible to the development of Alzheimer's disease and its related pathology at a much younger age than the general population. So if someone's got behaviour change in their 40s onwards, we're using that knowledge to think, well, could this actually be related to Alzheimer's disease or not? Velocardiofacial syndrome, or VCFS, much higher rates of psychosis. I think rates of schizophrenia-like illness in that in this population of up to 30%. So if someone's presenting with behaviour change, I'm thinking, oh, I need to specifically think about psychosis in this person, as well as ADHD and affective disorders. Williams syndrome are actually particularly sociable, and that's part of their behavioural phenotype. And so if someone does become more withdrawn in this particular and avoidant of social situations, we're much more suspicious of this change. And another condition, Smith-Magenis, where there is severe sleep disturbance, aggression and self-injury, much more commonly associated. So no one's going to ever expect people to remember the whole range of syndromes and their behavioural phenotypes off by heart. I do just make reference to these cheat sheets through SSBP website. I think it's a scientific study for behavioural phenotype. So just a handy reference. I still look back at them sometimes to just check in, have there been any updates about behavioural phenotypes? So understanding the cause of intellectual disability can help us to make sense of behaviour change. Then thinking about the level of intellectual disability, and I guess part of that may have been established previously on psychometric assessment, someone's been determined as having mild, moderate, severe or profound intellectual disability. But some of that is also, I guess, gleaned from that adaptive functioning screening. How much support does someone really need in their day-to-day life? And the level of intellectual disability really does impact on presentation when it comes to new or changed behaviour. Because when someone is perhaps at the more mild end of the spectrum, they more commonly do have the ability to articulate their internal experiences. So that they might be able to tell us they do feel sad or they're worrying about particular things. In the more moderate range of intellectual disability, symptoms might be more distorted. So an example of that, someone with a paranoid delusion, for example, or persecutory delusion, someone's out to get them. Someone with moderate intellectual disability might interpret that as that person's bad or that person's really mean. So it's, I guess, perhaps less well articulated, but you could understand that connection. And then, of course, when we're getting to the more severe and profound ends of intellectual disability, we're much more reliant on informants and the behavioural equivalence of symptoms. So that is things like changes in sleep, changes in oral intake as a proxy for appetite, changes in their level of motor activity. So if someone's really moving around a lot more active, vocalizing a lot more, could that be part of a hypomanic or manic type syndrome? So we're much more reliant on informants and observations with respect to behaviour. What are the neurodevelopmental comorbidities? I've made a reference to that and that overrepresentation in people with intellectual disability. And it does require reliable developmental history, which is not always easy to access, particularly, I imagine, in a primary healthcare setting. But that if someone does have ADHD or if they are autistic, that may in fact impact the presentation. A common one being self-talk, really persistent, problematic self-talk. Is that part of one's autism? Could it actually be psychosis? So what are the comorbidities? Would the presentation be secondary to medication changes? I always think more carefully about this in people with intellectual disability. Why? Partly because there are really high rates of psychotropic prescribing, and I made reference to that in the Beach data set, but there is broader international evidence that overall rates are higher than compared to the general population across a range of medicines, antipsychotics, anticonvulsants, and so on. That polypharmacy, so that's 2 or more psychotropic medications, a major problem in this cohort, and that actually then the side effects become a really important differential diagnosis when working out things that could be contributing to behaviour change. Then if someone's presented to you with behaviour change, a tricky question can be, should I investigate? And if so, to what degree? I mean, it is in part rely on one's ability to tolerate investigation. Some people have blood tests and scans, no problem. Other people really struggle to even get a blood pressure cuff on. And either ends of the spectrum are not ideal. I've had examples of over-investigation. So a person with Down syndrome in their 60s with clinically diagnosed Alzheimer's disease, but they're well-meaning epileptologists wanting to refer them for an FDG PET scan, which, in that setting really wasn't clinically indicated. But under investigation is also a risk in working with people with intellectual disability and presenting with behaviour problems. And I do recognise that part of the challenge is around accessing investigations as well. These have been very active discussions amongst my rehab physician colleagues and the Agency for Clinical Innovation, New South Wales Health Pillar, about what we should be doing about this, because there has been a proposal put forward by the College of Anaesthetists about tiered sedation pathways, which include everything from reasonable adjustments through to oral sedation with additional supports through to requiring a general anaesthetic. This really is a work in progress because there are no great New South Wales-based or Australian-based guidelines on what we should be doing in this area. So if people have had success, I'm certainly really keen to hear about it. But there are some easy read resources. I suggest looking at the QCIDD website if you are interested. And at the moment, it really does rely on local pathway development. So in summary, I think many of the skills are already there, but we are just thinking more about what reasonable adjustments we need to be making, what is the person's baseline behaviour, cognition and function compared to now, in addition to that usual comprehensive assessment that you pursue, including mental health and environmental contributors. But this is all really important to be then informing the management plan. So I hope people aren't sick of my voice just yet, but do feel free to interrupt me at any time. I will just keep going in the interest of time. To move on to some of the management considerations, because these end up being really often complex to disentangle what is contributing to what and how do I manage this, particularly with constraints around resource. And even I myself, I'm very reliant on NDIS support to implement some of the recommendations. So management principles will come really as no surprise, thinking about identifying and addressing all those contributing or reversible factors. That broadly, we are thinking about, apart from managing medical comorbidities, in managing behaviour itself, non-pharmacological strategies generally being first line. But there are specific considerations around medication management that I will spend a little bit of time thinking about with you. But really often does require a multimodal approach. For me, in the health setting, I am very aware of this divide between health and the disability sector. And the reality is, even in my role supporting a mental health service here at CESLED, I still am very reliant on NDIS support and allied health staff to be implementing many of the recommendations. Now, this is not at all exhaustive, and we really could spend an entire session talking about non-pharmacological management of behaviour, and that is really thinking about the functional, understanding the function of the behaviour. And we haven't spoken about that in detail, but it is really important to think about how behaviour can be a form of communication. And the typical ABCs, the things, the triggers, antecedents, the behaviour itself, and then the consequences. Having snapshots of this, I'm very reliant on data capture from a group home, and then for that to be summarised by behaviour support, at putting together really comprehensive plans, but what's often needed is just that quick half-page summary. Please provide me with the outtakes from your observations, which they then use to inform preventative and reactive strategies. And I guess they're often working very closely with occupational therapists to inform strategies around sensory needs and preferences of someone. So occupational therapists providing sensory assessments, incorporating that into the behaviour support plans, as well as using visual prompts to develop routine and structure with preferred activities to ensure that there is that structure for one's week. Speech pathology around optimising communication supports, making sure that's done. Do we need any assistive technologies? Is there adequate funding in the plan for that? And then more broadly, actually, is the level of support adequate? Is the SIL appropriate for this person's needs? And that is something that having someone driving that NDIS plan, like a support coordinator, actually really needs to be very heavily involved. So I don't have time to dwell more on this, but it's just to know that they are some of the common things that do come up in managing behaviours of concern. Preventative health screening, I think, is something that is a great opportunity for clinicians working in the primary care setting. And there have been advancements in recent years with the development of the national roadmap, and obviously needing to have greater incentives for greater uptake of things like the comprehensive health assessment program. There's one for adults and one for adolescents, as you probably know. But the reality is that there has to be major structural reform in order for GPs to be supported to implement this. And we've been very proactive in our advocacy there. There have been recent consultations around the MBS health assessment items review, and also the PHN business model and mental health flexible funding model. We've provided feedback on that recently. That's available on our website, and that's the link there. So I think actually preventative healthcare has a significant role in the I'm just seeing something here. People know. Oh, thank you, Chantel. Thank you. Chantel's just telling me that my screen sharing has stopped. It's still sharing on my end. Sydney, I don't know if you're there.
I still have it on my end as well. It might just be a setting thing for Chantel to just flip through them and see if she can get a different view.
Okay. Thank you for letting me know though, Chantel. That's great. Pharmacological approaches. It's been in the spotlight with the Disability Royal Commission. Things that, again, would be of no surprise, psychotropics being overprescribed. This issue around the distinction between treatment of mental illness and treatment of behaviour, which really has caused so many problems for us as prescribers. And I'm going to talk a bit more about that, but just for context, that there are a number of recommendations from the Royal Commission to address this that are actively, some of which are kind of actively in place, including a review of restrictive practices legislation in New South Wales. And another helpful I guess, guide or clinical care standard around principles of prescribing psychotropic medication. It's freely available. I think I may have hyperlinked this in my PDF. Apologies if I haven't, but just Google it. And it really does take us through those principles of prescribing. But in the interest of time, I won't go through all of them. But having put warnings around psychotropic medication, so that's things like antidepressants, mood stabilizers, antipsychotics, stimulant medications for ADHD, we do think that they have a role. And they certainly do if there is a diagnosed mental illness. Without a doubt, people with intellectual disability should have access to the same evidence-based treatment as the general population. But that we do, and that we do think about it in challenging behaviour, in behaviours of concern, when non-medication strategies have been unsuccessful, and I'll come to talking about that briefly, that ideally we're co-designing these treatment plans with the person themselves and their supports, and of course addressing other reversible factors. When I'm thinking about medication choice, it's like picking, I guess, psychotropic medication in the general population. There's personal preferences of the prescriber. There's an evidence base. There's also preferences of the person, their supports. But we do think more closely about the administration and monitoring requirements of the drugs, particularly things like lithium that need frequent blood tests that may not be tolerated by someone. We need to be thinking very carefully about polypharmacy and the potential for side effects. So I haven't spoken much about the potential for side effects, but the kind of wisdom is that people with intellectual disability will be prone to a range of side effects, even at a low dose of medications. And the ones we're thinking about are metabolic side effects, weight gain, the movement disorders, and sedation, particularly with that antipsychotic class of medication. So it is always this risk-benefit analysis. But we can also think about purely by indication, similarly to as we would in a general population treating anxiety, depression, bipolar disorder, or psychosis. But there are some additional considerations that I'll just leave for reference. We can also think about medications by common comorbidities. So knowing that epilepsy is the most prevalent medical comorbidity, we do need to be careful about prescribing medications that might lower the seizure threshold. So things like the tricyclics and many of the antipsychotics. We've talked about the metabolic side effects of medications, and this is very commonly problematic. And so we are left thinking about those more weight-neutral antipsychotics like aripiprazole or brexpiprazole in that setting. Effects on blood pressure, swallowing, and even those with, as I've referenced, younger onset dementia, particularly thinking about that anticholinergic load or the sedative effects that might contribute to their frailty burden, the risk of falls, and worsening of cognitive dysfunction. So can think about it by indication or medical comorbidity. But really, we are out in the wilderness. The honest truth is when we are prescribing for behaviours of concern, because the evidence for the effectiveness of these medications is very limited. Many of you may be aware of the role of risperidone and aripiprazoles for particularly irritability, but also aggression in specifically autism spectrum disorder. But otherwise, the evidence, there's just a dearth of evidence. So it is really going back to that initial assessment and thinking, could anxiety be contributing? Could it be a mood component? And if not, we are reliant on the antipsychotic class of medications. When psychological therapies have not been successful, when we're treating behaviours that are really severe and frequent and putting people or others at risks, and that it should still be offered in conjunction with psychological or other behavioural interventions. And the UK NICE guidelines of challenging behaviour and learning disabilities are well worth having in your back pocket as a reference. Before we wrap up, I do want to comment on restrictive practices because this is where prescribing for behaviours of concern does come under. It is recognised as a chemical restraint, and that, you know, is part of the broader umbrella of restrictive practices, being any intervention that has the effect of restricting the rights or freedom or movement of the person. So we're not treating mental illness. We're not treating physical condition. And the relevance here is the consent issue, sorry. So if the person has capacity to consent themselves, they are able to. But actually it is otherwise a guardian with a restrictive practices function. So in practical terms, that does require an NCAT application. So it is arduous, but it is very much part of this movement to reduce prescribing for behaviours of concern. And similar principles apply when prescribing psychotropics for behaviours of concern, identifying what that target behaviour is and how we're going to be monitoring effectiveness. I start very low doses. I go very slowly with the titration and only make one medication change at a time. We're monitoring for those side effects that we've spoken about. And really, it is helpful to have the rationale, the target behaviour and the consent documented so that we can go back to see, is this being effective and should this be continued? Monitoring is, of course, key, and that includes an action plan if side effects develop, and the opportunity to discontinue treatment if it has been trialled and it's no longer effective. And I think it's really important that we touch on deprescribing as we wrap up. There has been greater focus on this as a Maudsley deprescribing guideline on antidepressants, and I think anxiolytics now available. But broadly speaking, we really think, you know, the evidence is that it is possible to deprescribe if we are cautious in the way we go about it, one medication at a time. Ridiculously slowly would be my recommendation, that people need to be involved and on board with some of the withdrawal effects to say, hey, this actually isn't the behaviour recurring. This might be just medication withdrawal. And that actually we pick to do it at a time when people might otherwise be stable in their supports, their living circumstances. So making sure that NDIS team are on board throughout the deprescribing process. So, yeah, I'm sorry we don't have more time to talk about that, but I think it is really worthwhile considering. And of course, finally, just to refer on as needed, we have 2 statewide intellectual disability mental health services. The links are there. There's a great health team with the Centre for Disability Studies based in Sydney, but they are statewide. They don't have a psychiatrist, but they have a fantastic health team, as well as your local intellectual disability health team. Just at the end, I've left a bunch of resources, our IDMH Connect website to help people navigate these complex systems. There is an ID Health education website. Some of that content is free to New South Wales health staff. We're working towards making it free for everyone on the Knowledge Exchange Hub as that comes online. There's some child and youth specific training on our website, and then additional resources for prescribing as well. So with that, 1 minute to spare, I will stop sharing and invite any questions. Ruby.
Ruby, I've allowed your microphone, so if you want to turn it on, you have access to it now.
Thank you. Sorry, I can figure out how to do that one.
That's okay.
I was just wondering if we were going to have access to these slides at the end, if possible. I can't see if they were shared earlier or not.
I will actually drag them in right now. We will put them on the education website in our education library, but I'm going to drop the PDF in right now. It should go in.
Perfect. Thank you.
Thanks, Sydney. Yeah, you're very welcome to have them. Hopefully some of those links work. But any issues, do feel free to reach out. I'm on the New South Wales Health or UNSW email if you Google.
Ruby, it's not letting me just put the PDF straight in right now, but I will get it up. I do promise that in the recording. We will get them both up. If you'd like, I can just email it to you directly after this as well.
Fantastic. Thank you so much.
Any other questions? I should turn my camera back on so I'm not just like a ghost in the background, Rebecca.
It's okay.
And I've also, before you go today, I have popped a link to the Slido evaluation, the link and the QR code. So if you'd like to fill it out, we'd really love that. And Olivia, did you want to say anything? And we've got, actually, before you go, Olivia, we'll do Gabrielle. Let me just give her mic access as well. There you go.
Hi, thanks for that webinar. I'm just curious, I work in the Hunter and we have a great deal of difficulty getting GPs. We've got a bit of a critical GP shortage anyway, and we find it really difficult to get GPs on board with an interest in intellectual disability. So when we've got a patient we want to swap over to a new GP with an interest, we just come up against barrier after barrier. Is there such a thing as a list or a group, a GP group that have an interest in intellectual disability that we could access and then look at approaching them on a case-by-case basis?
Gabrielle, that's a really good question. I don't know, Sydney, if you want to respond from the PHN side, but I can also mention from the National Centre side that we are establishing a clinician network, and that will help us to identify people who are biased towards working with people with intellectual disability from a range of professional backgrounds, hopefully including GPs. But it is a really good question. So I don't know, Sydney, does the PHN...
To be honest, I'm not sure on the answer. I can look into it, but that's something I don't know off the top of my head, so I don't want to give the wrong advice straight up.
Yeah, it's a really good point though, Gabrielle, and yeah, if people have ideas about how to progress that. We have a similar issue with psychiatrists, and we've talked a lot about generating lists of people who might be available. There are challenges though with endorsing particular people and also keeping those lists updated. Someone really needs to take ownership of that. So I think, though, it is still very worthwhile considering.
Olivia, is that anything that Health Pathways would have anything to do with? And to be honest, I actually zoned out. I was trying to get that PDF still up, so I missed half that question. So I'm like, I don't want to answer. So I'm not positive. But Olivia, do you know?
No, look, we have the same problem on the Central Coast. I just had an email from a clinician at the SIDIST, and she was asking about a young person with severe intellectual disability, mental health, and she's trying to locate a GP for him on the Central Coast. So it's about scratching my head and thinking which GP you can call on and say, look, we can be in the background supporting you as long as you take this young person. So it is a big problem, and that was the reason behind having this webinar, Dr. Kons, is to sort of demystify that issue of intellectual disability and mental health to GPs, because they really are struggling with it, and they just don't know where to go.
Yeah, it is really difficult. I acknowledge that, and have a great deal of respect for people on the ground. So, yeah, I'm open to feedback. If there are other things that you'd find helpful, do feel free to get in touch.
Thank you.
Thank you for that. Any other questions?
I'm sorry I've gone over.
No, that's fine. I'm just going to quickly thank everyone and end the recording. Give me a second. Thank you again, guys. Hit stop. Perfect. Just so that